Oh, hello, everybody, and welcome to another episode of the CardioSeeds podcast, a space where we explore the rich intersection of cardiology, lifestyle medicine, and many factors that influence our heart and overall health. I'm your host, Dr. Svetlana Shamoun, and today we are super fortunate to welcome a distinguished guest from Toronto, Ontario, Canada, Dr. Aleksandra Pikula, a quadruple board certified expert in lifestyle medicine, neurology, vascular neurology, and lifestyle medicine. I already said that, and internal medicine. Dr. Pikula is an associate professor of medicine and neurology at the University of Toronto in Canada. She leads the largest multidisciplinary stroke in young adults program in Canada, and her research and clinical work are focused on cerebrovascular disease, it's brain vascular disease, stroke, and vascular brain aging in young adults, and stroke in women throughout their lifespan. So we are looking forward to a rich discussion about the interplay between heart and brain health, the role of lifestyle medicine in preventing strokes, and the disparities in stroke risks outcomes between genders and age groups. So you can read Dr. Pikula's full bio under the description in the description of the podcast. And so without um, any further delays, let's welcome Dr. Pikula to the podcast. It's my pleasure to have you on the show today, Dr. Pikula.
Well, thank you, Lana. And, this is really amazing. I hope we can call each other by first name.
Absolutely. I was looking forward to that. Thank you,
Thank you.
Alexandra. And
Yes.
let's get started. I have so many questions for you today, and I hope that we can cover all the aspects of this amazing field that you are in. But first, let me ask you this. As a quadruple, I have a hard time even comprehending how it's possible to have 4 board certifications. As a quadruple board certified physician, you passed to medicine, particularly, women and young population brain health and lifestyle medicine must be so cool and interesting. Could you share a little bit about your past, about your journey that inspired you to focus on that research in brain health and lifestyle medicine, its impact on brain health?
Well, now when you say it and when I hear it, it really does sound very exciting, at least to say, not to say how it was burdensome to go through all these certifications, but it was really out of the passion for the field. So, I mean, like for all physicians, we probably follow the same trajectory most of the time because we rather entered the traditional schooling when we were focused on learning and mastering how to diagnose and treat a disease. And it was only when I started my stroke fellowship in Boston and through the research on some novel risk factors for stroke and vascular brain aging at the Framingham Heart Study that I actually realized the importance of prevention. And the cohort that I was doing most of the studies was in mid-age population. However, the importance of prevention, even though we acknowledge that we did not really know how to properly implement other than other prescribing pharmacotherapeutics. So as you know, and I'm sure your medical school was pretty much the same. We only learn how to treat a condition, how to diagnose condition, and medical
Still, to the
school.
most part,
Still
medical
to the
school, that's
most
what it's
part,
about, right?
unfortunately,
Even
yes.
even in the West.
Exactly.
Yes.
And medical school really was not designed to teach us about nutrition, and even if we had some nutrition, I remember like having 8 to 10 hours of formal nutrition training
Mhm.
was really around specific conditions. I'm not even mentioning lack
We didn't
of.
even have that, Alexandra, in our medical school. Yeah.
There you go. And I think there is a lot of push to integrate that nowadays. But again, I don't think our students and our residents or fellows at this point have much more than what we have had.
Yeah.
And That's kind of the sort of the seeds from where I started exploring personally. What else I could potentially, share with my patients in the clinic.
Mhm.
And in the past 5 to 10 years, as you know, in cardiology, even longer, because we're always kind of lagging behind cardiology as cerebrovascular disease, at least by 10 years, I want to say. But the stroke care was successful, but mostly focused on acute stroke approaches through pharmacological approaches, revascularization interventions, which are really amazing nowadays.
Mhm.
But very little progress had been made in training or in translating the accumulated evidence that exists in the literature around lifestyle and preventive strategies for chronic conditions,
Mhm.
specifically for stroke, post-stroke dementia, vascular dementia, or even post-acute care into a proper lifestyle-based prevention strategies for what stroke becomes after an acute phase. It becomes actually a chronic illness. Uh,
Yes.
and that translation actually kind of in my mind working with young stroke population, which was my passion from get-go, really led to, okay, well, how do I offer more than just a prescription of pharmacotherapy, and more in the holistic way approach, while I did not have a formal training.
Mhm.
So I slowly actually grew into the quest on how those risks that I have studied at Framingham Heart Study, could be tamed with what we do on regular basis, daily or hourly, through our nutrition activities, positive emotions, social interactions, and many other aspects of lifestyle medicine. It's also
Mhm.
important to say that in addition, there were some health adversities in my family, and this journey intersected to some degree, exploring the lifestyle modalities for my personal interests. And,
Mhm.
as I grew into that, learning about health coaching, lifestyle medicine board certificates, like culinary medicine, uh, it quickly kind of intersected back with my professional interest around how to prevent stroke in young adults.
Mhm.
And it's really important to mention that through all this work, I also learned a lot from patients, from what I say, sort of almost like a whole way, discussions, understanding that us as a providers, we always look from the provider angle, what we think the patients do need. But essentially, there are unmet patient needs that we never talk about from their sort of lens. Um,
Mhm.
and through the health-based patient-reported outcome research that I started doing in past 5 to 6 years, really I learned that there is a dramatic need in integrating lifestyle medicine as a mainstream into an innovative or models of care that would support that. And
Mhm.
at this point, I'm reaching the level of expertise that is sort of opening door to what's called patient-driven clinic, with a great support of my team, and we're now establishing the first Canadian, probably maybe even North American Center of Excellence for Stroke Prevention and Cerebrovascular
Mhm.
Health, that
Mhm.
will expand outside of the box in terms of routine stroke prevention care. So,
Yeah.
summary, of
How
why
do you
lifestyle medicine. Yeah.
Yeah, yeah. So how do you explain to your patients that cerebrovascular disease is a continuum, and if somebody comes to you way too late, how in general it happens, in modern medicine, in I should say disease-oriented or disease-centered modern medicine, right? Um, how do you explain to them it may be too little, too late to intervene at that time? And what is your approach? How do you explain to them so they understand that early, conceptually early, as early in life as possible, um, lifestyle medicine modifications and living healthy lifestyles and what those healthy lifestyles are will prevent in the long run the cerebrovascular disease and adverse events. How do you talk to them about it?
This is a $1 million question. It's a great question, and really certainly touches upon what's missing currently. It's providing education and raising awareness around the importance of lifestyle medicine for prevention, not only brain conditions, but any condition. And
Of
I think
course.
it's really coming to a point where one should understand that life risks and modifiable risk factors, which we call them in contemporary medicine, such as unhealthy choices of smoking, poor diet, physical inactivity, poor sleep, obesity, high glucose, high blood pressure, even loneliness these days, they collectively are responsible for almost 90% of all strokes. And when you say that, then the question is where we as a provider sit in that world, and also where the public health sits in that world. And where are the incentives, and in my opinion, the incentive is always health over revenue. But I think that's that balance that is really driving this question that you ask, how. We usually don't have enough time in the clinics to do so, but I designed my personal Stroke in Young clinic to the extent where I spend at least 1 hour with each patient. There are obviously nurse practitioners and other providers that do certain educations, but we do focus in guiding a patient on recognizing that what they think they're doing well, it needs some adjustments. So I would have patients, that are highly trained professionals. They run every day almost, but they eat junk food because they're busy, they don't have time to cook, they have
Sure.
a lot of other
The
stuff.
usual. The
The
usual.
usual. So I always tell them, this is my mantra. It's like you cannot run your processed food,
You cannot run away from the processed
you
food.
cannot run it off
Right.
because it has to be a balance of all the pillars that mean lifestyle. So you have to sleep well, there are odd days for all of us. I mean, starting from myself, I don't do everything 100% every day.
Sure. Nobody does. Yeah.
And I think it's also acknowledging that when you're talking to patient helps, because there is this sort of also stigma in the society where if you are eating today's French fries, that means you are eating unhealthy and you are not following what you preach. I always say 80% make sure it's exactly what I'm talking about, and 20% it's with the comfort of life. We're not robots. So it's really motivation that is lacking in the current healthcare system. Not only knowledge, which I think it's the first thing, education, not only of providers, but also of families, as well as patients and the community.
Starting in early age,
mental.
early age education
Early,
is
the
a
earliest,
paramount.
exactly.
Yes.
The earliest,
Yeah.
the better.
I was looking at the American College of Cardiology recent articles by Valentin Fuster, and he really says that, making an emphasis on early life education, starting literally speaking, age 3, 4, 7. This is when all the conceptual positions develop, and the memory that people or kids have been taught during that age, they stay with people forever, for lifespan, including all the healthy or unhealthy habits. This is why, we say we eat what our moms put on our table and we continue cooking the same thing, through our lifespan. this is what he's talking about. When people reach their 20s, it's already the initial progression of cerebrovascular and cardiovascular diseases already there. And the reversing things may not be as easy, and the progression will continue if the lifestyles continue being unhealthy after people hit 20s. But then when we are in our 60s, for instance, right? 60s is only about quality of life. It's very hard to prevent anything at that age. It's very hard to reverse anything. Not impossible, but at that time, it may be a little bit too late, too little, right? So this early prevention and early education is so important, and it's already put in major journals, scientific journals. So I'm so excited about the future of lifestyle medicine, about the future of prevention.
Exactly.
Are you the
Yes,
same?
absolutely, absolutely. I think the palate, that for taste also forms up to age of 3.
Right.
So, if you're giving sort of mashed processed, food that is on the shelf somewhere in some stores,
Mm,
um, those are memories that are formed based on the experience, and
mm,
the habits are formed, when we grow. And it's, as you said,
yes.
very hard to reverse them. Not impossible, but I think
Yeah.
definitely something that
You
people
know,
have to work on.
with this cardio seeds, I will just tell you real quick that I am designing actually an actual physical product that will be licensed by CardioSeeds. So the card game for families with kids age 3 to 7, and
That's
then will
amazing.
be, for older kids, etc. But the first product will be so kind of in the game setting, in the play setting, to give them concepts of lifestyle medicine, proper nutrition, exercise, etc., social connectedness. So kind of envelop it in the play, in the game. I know
Very
that there are
important.
multiple
Very
research
important.
shows that game with young kids, game, and all those things really make them interested and really make them engaged, and learning potential increases when it's interplayed with the game. So kind of, you know, edu game, game edu, whatever it is. And yeah, so this is what
That's excellent.
we're
And
doing
it's very
on.
important,
Yeah,
given that, obesity among kids, fatty liver prevalence among kids in
yeah,
pediatric world is really rapidly growing. I mean, it's insane
yes,
growing. And, when you talk about stroke in young, stroke in young in last 10 years, and when I'm talking about stroke in young, it's below 50s, 55.
below 50. Yeah.
So it has doubled despite of all the acute care that we have at this point. Huh? So
Oh,
I think
yeah.
one has to give, and I think it's that healthcare paradigm shift that has to happen, and it's going to
Mhm,
happen. We're seeing
mhm.
the progress, and I think we're all moving into right direction. That it's not only about treating, but it's also about
About
preventing,
prevention.
reversing a
Let's
root
talk
cause.
about this a little bit
Mhm.
in depth.
Yes,
So,
yes,
when I was in clinical practice, I've always told my patients, if you have a massive heart attack, you just drop dead. But if you have a
exactly.
massive stroke, you become bedridden, possibly for years, and you become burden to your family. I was not shy to say that,
Yes,
to just kind of wake them up.
yes,
So I want to ask you, as a world renowned specialist in that field, what are the major lifestyle risk factors for strokes age group in younger age group, in older age group, and what would be where would you bank your money if you wanted to say, here is the best prevention possible. This is the best way to prevent strokes in young people and older adults, etc. Let's go for that.
yes. Yeah. So, I mean, I have to tell you that this has changed over last 2 decades. And the
Mhm.
reason it has changed is that the stroke was always a disease of elderly, huh?
Yeah.
And it was looked at added as a disease of elderly. And you're right, when a person has a stroke, they usually have a massive stroke. The death rate was higher, the disability rates were higher. This is dropping. So the death rates are going down, and simply because we have better preventive strategies that are pharmacotherapeutics for risks, such as AFib, such as hypertension, diabetes, and all that. However, as we are growing, as a society over the last 2 decades, there is accumulation of the traditional risk factors among young. And this is, I'm not talking about like 10% difference, I'm talking about 70% difference. And that's where we start talking about stroke in young had been a rare condition associated with rare causes, different genetic conditions, different cardiac abnormalities, different metabolic conditions, a random blood conditions. But at this point, we're talking.
Those are not modifiable, but what about the modifiable? You said the keyword accumulation of risk factors, lifestyle related risk factors. So what are they? How do they accumulate? How do they accumulate?
One that stands very high for all conditions, and we talk about that, and the focus of my research lately is on that. It's actually hypertension, high blood pressure. So the global burden of high blood pressure and high blood pressure being associated with stroke, cardiovascular disease, dementia, diabetes, I think about 90% of all had been attributed to hypertension. So the question is, how do you develop the hypertension? So it really goes into lifestyle. It goes into lifestyle, not exercising, eating processed food, eating salty food, drinking sugary drinks, accumulating excess weight. I'm not talking about a few pounds here and there. I'm talking about obesity. And now we know that 1 in 3 middle-aged adults is living with hypertension. And the projection is that number is going to double at least by 2025. So really, I think if we as a society are going to be doing anything to prevent stroke in young or stroke in general, it's essentially focusing on hypertension and of course diabetes, but hypertension, I think,
hypertension,
leader.
The societal, scientific societies changing their guidelines, ever changing the guidelines for high blood pressure. And I spent 14 years as a chief cardiologist with Clario, former ERT, which is the world's largest technology and innovation company for clinical trials. And the part of things, cardiac safety, I was doing this elevated blood pressure. So the consortium says that, even 2 millimeters of systolic blood pressure elevation over period of time, because we're not talking about, transient elevation of blood pressure. We're talking about, long-term elevation of blood pressure, increase risk of, significant negative outcomes, cardiovascular and cerebrovascular. Can you talk about this, about what's normal blood pressure, what's abnormal blood pressure, and how much those percentage decrease or not percentage, even the millimeters mercury increase or decrease in systolic blood pressure or diastolic over time? How does it reflect on strokes and cerebrovascular health?
Yes. So, I mean, when we talk about normal pressure, as you know, the numbers are shifting downwards. And now we talk about what's good and normal blood pressure is equal or below of 120 over 80. And, there are variations depending if you have some other modifiable risk factors such as diabetes or, prior cardiovascular disease, but the normal blood pressure for general population should be around 120 over 80. So even 10% or even 2 to 5% of millimeters of mercury increases the risk of stroke by 20 to 25%. The more important thing is to
That much.
illustrate to patient, I think, is if you decrease by this, what's the reduction of stroke? And there are large meta-analyses, huge studies. I'm talking about over 1 million people involved
Mhm.
that
Mhm.
found that blood pressure reduction of only 10 millimeters of mercury of systolic blood pressure, which is
Mhm.
top blood pressure, and 5 millimeters of bottom blood pressure or diastolic is associated with close to 40% of stroke reduction.
Mhm.
And this was for all clinical trials that had been out there.
Mhm.
Now, the
Mhm.
question, how do you do it with
How
diet?
do you do that? Yes.
Yes,
How do you do it
because with
with
medication
lifestyle
is easy,
modifications, not with
Yes.
medications? Yes.
Yes, so with diet, I think it's also important to understand, that salt in the food is something that we should watch around, how much you eat salty food. And that's the processed food that we talk about, the chips, all the palatable food, that people are pretty much addicted to. It's hard to stop doing that.
Mhm.
So watching that, you cook from scratch, you don't add extra salt, the salt content, the daily salt content is 2.3 grams.
Grams. Mhm.
Yes, while actually the recommended dose is 1.5 for
Mhm.
even better prevention. And that equals for cardiovascular as well as for cerebrovascular disease and even
You
for
mean in the current US guidelines, right? Dietary guidelines, it's
yes,
2.3, while the
yes,
optimal is much lower, almost half
exactly.
that number. Yes.
And that's interesting, and again, we go back to education, huh?
Mm.
And we just did recently a study, and I just reviewed some data last evening because we're just kind of cleaning for the mid analysis.
Mhm.
We're looking at the knowledge around lifestyle medicine, and then asking also patient about what they do to really compare the knowledge with their practice. And
Mhm. Mhm.
the there is a massive discrepancy between two. First of all, very many people do understand what's normal blood pressure, so they answered the question correctly because we had sort of a
Yeah.
pre-test for all,
Mhm. Right.
and they know what they need to eat. But when you talk about what they do and when they test them and when you do that through focus groups, you realize that that discrepancy is massive. So
Right.
really, it's maybe not only education, but it's the barriers and motivation.
Uh-huh. And how do you change that?
Yes. Well, I don't know. The answer is very sort of in the air at this point. I think we have to go back to patients and understand what their needs and
Mhm.
what they think. And I think you do some of that, reclaim
A lot.
work,
Yeah. Yeah.
creatively engaging them in what essentially works for them, not what we think they need to
You
do.
know, Alexandra, I think that, most recent studies and multiple studies showed really huge added benefit of behavioral coaching to
Exactly.
everything that we do. And I think that the future of behavioral coaching is bright in that regard because it's about sustainability of modifying behaviors. This is what we're looking at, not
Yes.
just knowledge, not just instructions, but
Yes.
smart goals, XYZ, how you can, break that big, large goal into smaller parts and smaller fractions and achieve it with help of behavioral coaching, this motivational interview, and all that stuff that is involved in health and wellness coaching. Because yeah, I found it extremely helpful to uh, to do behavioral coaching rather than any instructions, any just recipes or prescriptions per se,
Exactly.
right? Yeah,
Exactly. And I think that goes also into what, but the question is, how do you bring that to a public level, individually
right.
when you're doing, with your client or me with my patient, it will work. But that's on the
Yeah.
individual level. And, I always say if I change the life of one person, I protected a lot of stroke, because that person also delivers that to their family, their loved
Mhm.
ones, the partners and, kids and everyone else. But I think at the public level is something that we should work. And, some of my research is around that. But again, it goes into initial steps on assessing your population, what
Mhm.
their motivations and barriers are around
Of
the
course.
healthcare system. So I
Mhm.
mean, we just did and finished study last year, and it's going to be published soon, looking at what are the positive and negative experiences with healthcare system around lifestyle medicine and around prevention. So what we
Mm.
are seeing, which is kind of frightening, and I think COVID had to do a lot with that, and we're exploring that now. Second piece through the focus groups and qualitative research is that um, people got, and it was eye-opening finding, there was increased concern around weak trust between patients and the treating team and providers.
Mm.
So and that's
And
something.
why is that, do you think?
Well, I think providers are busy. They don't
Mhm.
have time. We can talk a little bit about your work as well, a burnout, how we relate to our patients, when there's
Mhm.
a high volume practice, when you're burned out, there is a lot of sadness, depression, there is no sort of a value based care,
Mhm.
around and you're almost delivering the algorithm of care.
Mhm.
Make sure the lipids are addressed, make sure blood pressure is addressed, make sure person is on aspirin, make sure you tell them to eat more fruits and veggies, and that's kind of it. But there is no this sort of a close connection and transfer that one has to build in order for person that is on the other hand, which is a patient, would
Mhm.
embrace that
Right. Right.
home and say, you know what, Dr. Pikula told me this really is going to work for me. Let me work on it.
Mhm. Mhm.
So I think that's
Yeah.
that's
Yeah.
that's sort of the communication is a little bit um, uh, fractioned.
Mhm.
And I mean, as much as virtual care helped us, I think some forms of hybrid um, you know, um, connection has to exist
Mhm.
in order to have those human touches,
Right. Yeah.
between the provider and the patient, or a
I
provider
think,
and client.
right. I think this disconnect happened way before
Before,
COVID.
yeah,
So,
yeah, yeah.
yeah. So I think, this is such a multifactorial issue, this whole thing about the disconnect, about the lack of trust, about burnout and everything. But I think if one thing COVID had in positive, gave us the positive thing, is the understanding of those problems, right?
Mhm.
And openness that we can talk about those problems with one
Yes.
another, with our patients, etc. And I think, Alexandra, I have a feeling here in the US, at least at this point, the whole medical communities just started waking up after COVID and just started realizing that, we essentially are hijacked by big money, by insurance companies, by those hedge funds or private equities that own healthcare in the United States, obviously, and they have their own agenda. And usually administrators are kind of squeezed in between the rock and the hard place, between the providers who are burning out, but they still need to follow the agenda of board or the stakeholders and push productivity, etc., etc. But at the same time, this with COVID, that our chronic languishing turned into a major spiraling down with burnout and everything, and patients disconnect. I think the administrators also are getting slowly but getting on board with helping us to construct,
Yes.
multidisciplinary teams. On the national level, this issue of lifestyle medicine is becoming very hot now, and it's been published in major scientific journals. The need for incorporating lifestyle medicine into not only into our practices, but also into our own lives and medical education, starting with medical school and residencies and fellowships, and also incorporating those components into early education, the population education, including the studying population health and those things that determine the social aspects, access to healthcare, et cetera, et cetera. So I think the wheels have started moving. They
Absolutely.
started moving slowly, but they have started moving. And I think we have a unique, not only perspective, but we are uniquely positioned as lifestyle medicine, cardiologists, neurologists, et cetera, and members of the American College of Lifestyle Medicine who do a lot
Yes.
of this groundwork, out there with not only with patients, but also with administrations, with policymakers, with the general population, with the kids, et cetera, and with our trainees also. Trainees, this
Yes.
is our future, right? So they don't leave medicine, they don't, kind of branch out into non-medical specialties, and they know how to take care of themselves. They know how to incorporate pillars of lifestyle medicine in their practices and organize multidisciplinary teams. That's the future.
Yes.
So I hope that lifestyle medicine will be one large pillar of medicine in the future for both the US and Canada and other countries.
I
Um,
totally agree. I think it's absolutely moving into the right direction from
yeah, I
all
think
angles,
our work
Yes.
just started, right?
Yes.
But
Yes. Yes.
Alexandra, listen, you
Yes.
mentioned COVID, and I'm still this, in my mind, in this COVID, thinking about COVID. I
Mhm.
wanted to ask you, as a neurologist, there are so many people who complain to me and to other physicians about two things: brain fog and chronic fatigue post-COVID. So brain fog is like now is the word of the day, right? Everyone has that long COVID and has brain fog. Can you potentially talk about neurological mechanisms that are behind those symptoms? What are they? I know that some studies did, literally speaking, like brain scanning in all of those patients, to see what was happening.
Wow. Okay. Well, excellent questions. $1 million question. If we knew the answer, people wouldn't be complaining. But
Right.
yes, it's a real thing. It
Yeah.
seems like, first of all, I think it's over 650 million people had COVID in the world. Huh?
Yes.
So it's a huge number. We know that people with in general long COVID have a variety of symptoms, as you
Hmm.
mentioned, tiredness, lack of energy, or if we call it fatigue, difficulty concentrating, remembering, thinking, which is kind of description for brain fog.
Hmm.
And that change in smell or taste, which kind of is connection to brain through olfactory nerve.
Hmm.
That some are entertaining as those that had it might have higher risk of what's called brain fog or overall um, um, long COVID.
Hmm.
People that are elderly, people that have more risk factors in the background, such as mostly diabetes and other cardiovascular conditions. And how much work is done at this point to uncover the possible explanation? I want to say very little.
Hmm.
I think that's something that in the future we'll be reading a lot about. There are mouse models that people are trying to explore the pathophysiology and biological plausibility around that.
Hmm.
That goes around neuroinflammation and
Hmm.
pathobiology of classic organic inflammatory conditions that affects the myelin, neurons, brain cells, the connectivity
Right.
that can essentially lead to neural cell dysregulation.
Hmm.
But if we talk about human studies, there are only few actually that had looked into cerebral blood flow, into the structural changes.
Uh-huh.
Small changes had been shown in several studies. One actually was led here at one of the university-based hospitals, Sunnybrook Hospital. They looked into small sample of people to understand their long COVID symptoms and how that could impact the brain. And they analyzed the MRI scans
Hmm.
and actually found the decreased blood flow, some measurements of the brain, energy utilization was changed. They documented changes in the brain physiology, but the results are very small, so you cannot really extrapolate that. There is a lot of research that needs to be done to really say more about it.
Yeah.
There are other studies that looked at structural brain changes in certain um, parts of the brain, like basal ganglia, like deep structures that control the movements as well as feelings. And,
Mm.
you know, there are changes on structural imaging within those structures underlying the persistent fatigue experienced by patients who had COVID syndromes.
Mhm.
There's some evidence about that as well, but it's premature really to really say what is the key element that will explain the post-COVID fatigue and related
Right.
psychiatric
Right.
or
So the
neurocognitive.
work is still ongoing, obviously,
Work
and
is
maybe
still
just
ongoing.
started. Yeah.
Yes.
Well, let's switch gears.
Mhm.
I want to go back to our women and young adults, right? So we touch bases about the vascular aging, and the reasons
Mhm.
rooted in lifestyles for younger adults who are, as you said, accumulate risk factors, right? What about sex disparities? What about sex disparities in stroke risks, outcomes, prevention, etc.? Your work has been recognized
Mhm.
nationally and internationally in this arena. So, what's the current understanding of the situation? Women versus the others, women
Yes.
versus guys. Yeah.
Yeah, I mean, most of the work that I did in Young had that overarching sort of focus on sex disparities, not only on risks and prevention, but on outcomes and more so on what influences the
Hmm.
differences. And studying just the biology simply doesn't cut it because we're social beings. So I think we're then extending that into the gender as well. Social, cultural, lifestyle impacts on those differences, and the whole field is emerging. And I have to say, what we have known about sex disparities had
Hmm.
existed for many, many years, and it was recurrently regurgitated through many studies. And there is some new emerging data coming around WISE. But in summary, when you talk about these differences, we learned from the studies and from our work that women have more strokes than men.
Hmm.
Lifestyle risk for stroke is 1 in 4 compared to 1 in 5 for men. Young women now have higher burden and impact from traditional stroke risk factors, increased by 30 to 40% over past decade.
Wow.
So
Yeah.
it's really a call for better primary prevention, which we don't do as a provider. So it's mostly family physicians who do it. So I think we have to bring that knowledge back and educate them about the impact of risk
Mhm.
factors. Perhaps push the screening earlier for many things, not only for solid chronic conditions that are associated with risk for stroke, such as hypertension, diabetes, hyperlipidemia, which we kind of get stuck on, but actually before those three happen, huh? Which is, how many hours or minutes a day you run, what do you eat, working on obesity, on overweight aspects of risk, that can actually ameliorate many subsequent consequences. Important thing is also for women that when stroke happens at older age, they come with a larger burden of chronic problems. And hence, it's the perception that they do worse. But when you adjust for all this, actually, they don't, because they simply have more burden of chronic illness that leads to poor outcomes after stroke. One important thing is also when talking about the differences is obviously, biological part. There are three critical lifestyle or life stages in women during the childbearing age, during menopause and during elderly life stage, when there are certain hormonal differences. In childbearing age, there is more use of exogenous hormones, contraceptive pills. Every other girl is now on contraceptive pills.
Sure.
There are certain things that they need to know in terms of the stroke prevention. Having migraine, smoking increases almost 16 folds stroke risk in someone who is
both having migraine and smoking, or either
complex
or?
migraine. Yes. So can increase the risk of stroke, mostly venous strokes, but still, it can be
what's the mechanism?
The mechanism is increased coagulation. Most of the time is the mechanism. During menopause, you have due to a loss of estrogen, so there is no enough. So we lose the protective effect of estrogen vasculature. And there are many other things. Women during the menopause start accumulating rapidly risks around metabolic syndrome, diabetes, hypertension, compared to men of the same age. And the effect of those risks are much more profound for women. Studies had shown numerous times that diabetes and metabolic syndrome during mid-age increases risk of stroke by 3 folds in women compared to men of the same age. So even the men with diabetes at 50s or 60s have less effect of diabetes on stroke risk than women, because
than female, and maybe even in the younger age.
So there are a lot of analyses around that diabetes and cardiometabolic syndrome significantly increase its Alzheimer's risk in postmenopausal women.
How about that?
There are certain differences that we have to study. We have to understand them in order to provide better prevention, better care. We're simply different.
Yeah. What about the outcomes? I mean, the cardiovascular outcomes in females have been traditionally worse than in male counterparts. What about cerebrovascular outcomes?
So, in terms
stroke outcomes, essentially.
Stroke. Mortalities are higher, disability higher, post-stroke fatigue is higher. More women end up in a long-term care after stroke than men of the same age in elderly population. But there's some social aspects of why. So I don't think there are major differences, in fact, because when you adjust for those social differences, then those sort of outcome differences disappear.
They even out. I get it. I see.
So I think it's all about prevention.
Right.
Going a little bit, a few decades earlier. And we really, as a community, as a professional community, we really have a lot on our plates. And I think we're moving the right direction. But I think that lifestyle medicine is the way to go. And it has to be part of the mainstream.
Medicine. Mainstream medicine. Aleksandra, to wrap it up, to honor our listeners and viewers' time, I want to ask you this last question. As we said, with the providers. We talked about the providers, and we touched on burnout during our conversation. What are the risk factors, cerebrovascular lifestyle-related risk factors that are related to burnout, perhaps? How burnout may affect our own as providers, as healthcare, professionals, outcomes in the future if not addressed.
Honestly, I mean, I'm almost, I want to sort of send that question back to you because that's
Right.
your
Yeah.
expertise, and you're really a big advocate for work-life balance in the
Right.
context
Yeah.
of cardiovascular and hence cerebrovascular health. I think talking about the effect of stress and anxiety, and the burnout and imbalance altogether is huge. And
Right.
how that impacts the brain health, cardiovascular health, it's really important to understand.
Mhm.
I think there are a couple of explanations, and maybe you can touch upon few, but I feel like it's mostly going again into the behavioral aspects of lifestyle medicine,
Right.
where when you're under stress, when you don't sleep, when you're unhappy with your work life balance, you
Of
tend
course. Of
to
course.
avoid exercise, you eat poorly, people do drink, they go
Sure.
out to the substances. And
Exactly.
please, can you share your thoughts
Of
on how
course, of course. Alexandra, we are on the same page, I think, with the
Mhm.
fact that vascular disease as well as vascular health is a continuum, right? So the
Exactly.
cardiovascular health doesn't exist without cerebrovascular and vice versa. So when I approach my patients who are frequently healthcare professionals who are under chronic severe stress or experiencing burnout, I say, we cannot just address one aspect of your lifestyle without addressing the others. It doesn't work this way. We have to approach the whole thing holistically, change your behavior, try to change your work environment, et cetera, et cetera. And as far as the mechanisms, I totally agree. In fact, we just wrote this article together that will be published at the Mayo Clinic proceedings, right, about the
Yes.
impacts of lifestyle on different aspects of cardiovascular and cerebrovascular and metabolic
Mhm.
disease and health together. So the stress response can lead to all of those things like increased heart rate, elevated blood pressure, inflammation within blood vessels, and it's systemic. It's not just the heart or brain, right? So over
Exactly.
time, obviously, it contributes to atherosclerosis and other related issues. But, essentially, has been a lot of work in um, highlighting atrial fibrillation as one of the risk factors for both strokes and cardiovascular complications, and it's related to burnout. And on top of stress and burnout, increased risk of unhealthy behaviors, including alcohol consumption, that in turn, excessive alcohol consumption, leads to bouts of atrial fibrillation, high
Mhm.
blood pressure, heart failure, and stroke, causes cardiomyopathy, as a direct effect on heart muscle, and also causes direct brain damage as a neurotoxin, right? And as you already mentioned, the cognitive decline, memory problems, increased problems with, neurological disorders such as Alzheimer's disease. They're all direct consequences of burnout and stress that have been unaddressed. So when I say, that stress is one of the major risk factors, in my opinion, major risk factors for both cardiovascular and cerebrovascular disease. I mean just that it covers it all, and it puts stress on the whole system, including, our heart and blood vessels and brain, et cetera, et cetera. So yeah, we use holistic approach with our Reclaim. Reclaim is a abbreviation for our approach of recognizing, evaluating, charting the course, introducing love or self-care. L stands for love and self-care. A for action or advocacy. I, I go different ways with I, but it's inspiration usually to others around you, and M for maintenance and mentorship. That essentially people or clients who complete reclaim program, they usually feel like they can propagate the knowledge, they can propagate their enthusiasm for a healthy lifestyle, building resilience, et cetera, et cetera, et cetera. But yeah, those things, this is what
This
we
is
do.
really amazing. Thanks for sharing, because I think that's exactly what's missing in healthcare providers world. A little bit of compassion,
Right,
for your own health,
right.
in order to essentially be good for others. So I'm
And
really
yeah,
excited
and
to learn more about your
essentially,
work and the
right.
outcomes.
And you
Yes,
know what I tell them? I tell my clients that, you take one program and then you educate two others, and
exactly.
then you mentor many in the future. So it should work like mushrooming, like tentacles, all
Yeah.
this knowledge and all this goodness that we carry with us, and our knowledge of lifestyle medicine pillars and behavioral coaching. Well, Alexandra, listen, I am amazed with all your insights and the knowledge. And thank you so much for being on the show today. Thank you for the amazing discussion, all your insights. We have learned a lot, at least I've learned a lot today. I hope our listeners do the same. And thank you for your time.
Thank you, Lana, for having me. And I'm looking forward to working on so many things together, and moving this lifestyle medicine forward. It's really
Absolutely.
pivotal work. Thank you.
Absolutely. Agreed. 100%. And for
Thank
all
you.
our listeners, thank you for being with us today. Please follow CardioSeeds on social media and our CardioSeeds podcast, and take Reclaim by CardioSeeds program to reach your best health, both medical, mental, and physical. And thank you for you being here today. See you soon. Goodbye.